I've had the opportunity to collaborate with many therapists over the years. I've worked in two different states, both in the Baltimore area and here in northern New Jersey. And one of the things that I think is always interesting to and important to think about is when should you as a therapist refer to a psychiatrist? And I find that there's a wide range in terms of each therapist's perspective on this. Some of it depends on your training. Some of it depends on your experience and your comfort level with what you're doing clinically. Some of it, frankly, depends on availability and access to psychiatry. In a perfect world, if there's always access to psychiatry and child and adolescent psychiatry, which I know is a challenge in some areas of the country, there's an art for you as a therapist to knowing, when do I refer? Do I refer when I'm in crisis, when my patient's in crisis, where I've done everything I could and now we're in trouble, now we're concerned about safety, then I refer? Or do I refer right off the bat? I see a patient once and I go, hey, let's get a psychiatric perspective, not that necessarily that the person needs medications. Or do I refer when I think my patient might need medications? I find that that's probably the most common perspective for a lot of therapists, is where you come to the conclusion as a result of working with someone that, hey, you know what? I think we should consider medications. And there's different perspectives on this, and where people could differ in terms of that. My thought is to try to be a little bit more nuanced. That it's important when you're working with someone to know what it is you're treating. And when I say that, I don't necessarily mean in a DSM-5 kind of category with a label, that we're going to label someone with major depressive disorder, recurrent, or generalized anxiety disorder, or ADHD. But in terms of what am I treating as an A, is there a primary psychiatric issue in the first place? Is this a primary behavioral issue? Is this a developmental issue? Is this a family dynamic issue? And where I think it can be helpful, again, not necessarily that the patient needs medications, is to get that perspective for someone to do a good, thorough diagnostic evaluation to pick it apart, to provide guidance for your therapy, not necessarily to replace your therapy, but to give guidance. And we do this in medicine all the time, which is a reflection of my training, where we consult. We consult different specialties to guide us to say, hey, maybe you should go see a neurologist to just give me their perspective on this, or a gastroenterologist, or a cardiologist, or sometimes a gastroenterologist will refer to a psychiatrist, or a cardiologist will refer to a psychiatrist, where we're asking for consultation. So I think one of the ways I look at asking for a psychiatric evaluation is a consultation, not necessarily to prescribe meds. I think too often we've looked at referring patients for psychiatric evaluations purely to medicate. And I think we need to be more nuanced than that. To me, I would say, hey, I think the biggest value of a psychiatric evaluation is a consultation, a diagnostic consultation to guide the treatment process, not necessarily to medicate. And I would hate for patients, if you're listening in on this, to think of going to see a psychiatrist automatically so you can get a prescription. That's not the way this should be done. I think the most prudent way to think about psychiatric evaluations is a consultation to guide the process, to guide the treatment, to provide an opinion, to guide where to go. And remember, part of that evaluation can be you don't need medications, or there isn't anything psychiatric going on. But it guides the process and it helps to figure out, where do we go from here? What should we look for? What are some things that would say, hey, yeah, you know what, you should come back and see me if this happens. So a good psychiatric evaluation would be diagnostic, would tell us what we think is going on, and would guide us in terms of what to look for, what to anticipate, in terms of prognosis, where is this going? Hey, when do we need to switch courses? And to guide the therapeutic process. Hope that's helpful. Just one perspective of a psychiatrist.